Hi, I'm Dr. Mehboob, MD Ophthalmology from AIIMS, New Delhi. And today we are back with the very important session, that is the recall questions of CET May 2021. Why it is very important to recall this repeated questions? Because directly or indirectly, the question is being repeated in the INCT exam frequently. So if you know the question, if you know all the concepts behind that options that they have given, then you will be able to make most of the MCQs, not only in ophthalmology but in all the subjects. This is the same. So it's very important to revise these recall or repeated questions before the exam with conceptual basis. Okay, and before we further go for this recall questions, let me just subscribe and share this videos to others. And one more thing, that I have uploaded a series of images in ophthalmology. There's the part 1 have been already uploaded, and the subsequent parts is about to come. That is consisting of image in ophthalmology. Before exam, all of the ophthalmology's images which is important for the exam, it will be uploaded. So for the updated view, just share and subscribe. Thank you. Now before we should start, just start with the first question. So the first question is saying that safe strategy for trachoma is including all except. You all know about the trachoma. It's a mainly causing the conjunctival disease. Trachoma, the strain which is responsible for the trachoma is Chlamydia trachomatis A, B, BA and C. Okay, A, B, BA and C. This is the main strain which is responsible for the trachoma. Now WHO has acquired this safe strategy is by the WHO, none other than WHO. So safe strategy, every single word has a meaning. It's very important. SAFE. So options are surgery for trachiasis, antibiotics, facial cleanliness, evaluation of control program. So what is the answer? S for surgery is the right thing. So let me tell you, SAFE. Just pay attention here. SAFE. S for surgery. Surgery for trichiasis. Okay. A for antibiotics. What antibiotic you will use? Azithromycin 1 gram single dose, right? 1 gram single dose. This is also a potential question. F for facial cleanliness, and E for environmental hygiene. Environmental hygiene. So this is very important. S for surgery for trichiasis, A for antibiotic, and what antibiotic that you will use? Azithromycin 1 gram single dose. This is very important questions for the future. Facial cleanliness and environmental hygiene. What is not present in the option? Surgery is present, antibiotic is present, facial cleanliness is present, evaluation of the control program is not present. Not the full form of E. So answer here is E. So this is the ruled out options. Now since you know that this trachoma is a very important question, and most of the time they have asked the question over trachoma. Not only this, they can ask you further questions also. So let me tell you some of the basic things of the trachoma. So I have already told you that the trachoma is caused by the Chlamydia trachomatis type A, B, and C, right? Now coming to this photo, can you see this, the papillary things, follicular things are there, right? What is this? What is this? What is this? What is this scarring? Subtarsal scarring. This subtarsal scarring is nothing but it is Art's line. This subtarsal scarring is nothing but it is Art's line. Now what is this? See the matted structure of the lashes. Eyelashes is being rubbing over the cornea. Eyelashes is rubbing over the cornea, right? So this is very important to understand. Now Art's line have been asked in the exam, and they can show you this photo. This is very important. Trichiasis, for this reason that you are going to go for the surgery. Now coming to, this is very important, WHO classification of the trachoma have been asked frequently in NEET PG also and NICT also. Okay, so what is, how will you remember this classification? Very simple, just remember, I know most of you also know about this, but just for recapitulation, Fisto, F for follicle, let's see follicular here, I for intense, T for trachomatus, S for trachomatus scarring, T for trachiasis, and O for opacity. So F is follicular, I is intense, S is scarring, T is trachiasis, and O is opacity. Now what you will do, they have asked one questions in the AIIMS also about the follicular stage, when you call it a follicular stage. So the answer is here is that whenever the follicle size is more than 0.5 mm, when the follicular size is more than 0.5 mm, and when the number is 5 or more, 5 ka, you just remember 5, 0.5 and 5 or more, and in the superior tarsal plate, this is a very important criteria, in the superior tarsal plate, then only we call it a follicular stage. Now can you see that until this 1, 2, 3 stages we can give antibiotics. Okay, in the trachomatus trachiasis and corneal opacity we are going for the surgeries. Okay, so this is about the first question, that is very important and you have to remember all these things. Now coming to the second important question, the most common, let me tell you what is the second question is telling you. The most common tumor of lacrimal gland is adenoid cystic carcinoma, non-Hodgkin's lymphoma, pleomorphic adenoma, mucoepidermoid carcinoma. See, the answer, that is very straightforward question. Most common lacrimal gland tumor. See, this is not asking whether it is malignant or benign, it is asking overall. So overall the answer is pleomorphic adenoma. The answer is pleomorphic adenoma. It is the most common benign form of the tumor, which is of the lacrimal gland, and where it is formed I will tell you. And if they ask you that most common carcinoma is malignant, okay, they ask you the most common carcinoma, so the answer will be this is the most common carcinoma, matlab malignant tumor of the lacrimal gland. Okay, carcinoma, 50% of the cases are having this. इसके अलावा there are other types of carcinoma also, like the pleomorphic adenocarcinoma, not adenoma, adenocarcinoma. Mucoepidermoid carcinoma is also a malignant tumor. So these types of the tumors are of the lacrimal gland only. But if somebody asks you what is the most common type of the benign tumor or overall tumor, that is the pleomorphic adenoma will be your answer. Let me show you something. In the benign form, this is all I am showing you pleomorphic adenoma only. This is only pleomorphic adenoma only. Can you see this? Because of the epithelial keratinization, there is also the epithelial pulse. See here, there is a epithelial pulse. Just see, there is a epithelial pulse can also be seen on the histology. Now the location. See this part, this area is highlighted. It's the superior nasal part. The position of lacrimal gland is also here. So obviously the location of this pleomorphic adenoma is usually supero-nasal. Right? Now it is orbital and it is just below the lid. It is also supero-nasal, but it is below the lid and it is in the lid. It is going in the lid. Now on CT scan, can just see the CT scan of this. CT scan. This CT scan is showing that well capsulated smooth margin of the mass, of some mass, homogeneous mass, okay, not heterogeneous. And also you can see there is no destruction. This bone, see this bone is quite intact, right? So there is no erosions, indicative of benign lesion, right? So this is very important. However, in the carcinoma, the bony erosions will be seen, irregular metastasis also can be seen. So this is about the pleomorphic adenoma. So what is important here in the pleomorphic adenoma, that you should know the most common location of this and the photo that is very important. That can be asked, or they can give you the histology of that photo, and that they will ask the questions in the future. Remember this. What is the most common route of the spread of the retinoblastoma? This has been asked quite often and repeatedly in the MCQ in the INICET AIIMS. Okay, so the question options are direct invasion, hematogenous, optic nerve invasions, lymphatic spread. Basically, these all are the route of the spread. Retinoblastoma can be spread by all of the route. Okay, so suppose I am making, this is this photo. This is optic nerve, not a good photo of mine. This is optic nerve. Now this is the lens. Okay. So if suppose our tumor is here, so the most common route क्या होगा? Just see, optic nerve invasion will occur, obviously will occur, but it is not as common as the direct invasion of in the surrounding area. ये सराउंडिंग एरिया में ज़्यादा इन्वेड करेंगे कंपेयर टू द ऑप्टिक नर्व इन्वेजन. हेमाटोजेनस स्प्रेड एंड लिम्फेटिक स्प्रेड will only take place when there is an invasion or erosions of the blood vessels, right? So obviously, though all the routes are the route of spread of this retinoblastoma, but the most common is direct invasion. So the answer for this question is the direct invasion. Okay, so this can be asked, and important to understand that the retinoblastoma is the most common primary intraocular tumor of the childhood. Primary intraocular tumor of the childhood. This is very important to understand. Some of the properties that you should know that about the retinoblastoma is that it is mostly occur in the below the 3 years of the age. Follow the Knudsen hypothesis. Knudsen hypothesis. This is very important to understand. Knudsen hypothesis of the two hit hypothesis. Basically, it has a calcification, and there is a leukocoria. You know about the leukocoria. There is so much of the DD leukocoria, and most common DD of this condition, most common differential diagnosis of this condition is Coats disease. And how to differentiate it? That the Coats disease is basically occur in the first decade only, but around 8 years, no calcification, usually unilateral, and this retinoblastoma is bilateral, and this Coats disease is unilateral. And one important thing that the Coats disease have a predilection for the male is more than female, but in the retinoblastoma there is no predilection for the male female. So basically this is just the quick review of the differences that is very important to distinguish. It is unilateral, it is bilateral, sorry, retinoblastoma is bilateral, it is unilateral. This one is having a no predilection for the any sex, that is male is equal to female. It has a predilection for the male. It is around, this Coats disease is around 8 years. This retinoblastoma is around 3 years. It follows the Knudsen two-hit hypothesis and showing the calcification. It does not follow the Knudsen hit hypothesis, and there is no calcification on CT scan. This is very important to understand. Coming to, without wasting time, the fourth important question, that is identify the site of the lesion. So this is the Humphrey visual field. Okay, now can you see this Humphrey visual field? आपको मैं दिखाता हूँ, ये आप देखो. This is the lesion. Can you see? Can you tell me where the lesion can be? चलो इसके concept को समझते हैं. First, let us understand the concept behind this, and then we will come to the question. That's very important. And one short question will be from here. See, what is this? What is this? This is the visual field they are talking. This is not abnormal. Okay. Now coming to this point, don't go for the figure. I will tell you. This one is an optic nerve. This is optic chiasma. Okay, this is the optic tract. Up to the retinal geniculate body there is an optic tract. Okay, and then there is a radiation. This is called optic radiation. This is called optic radiation. This one is optic radiation. So this one is optic radiation like this. Okay, this one is an optic radiation. So what I have marked is the optic radiation. This is the visual cortex. This is the visual cortex, right? Now can you see? The one thing is that obviously let me draw this photo. Let me draw this photo. Now just see this, that this is this part, I mean, if it is a nasal field, I mean temporal field, if this is a temporal field and if this is a nasal field, if this is a nasal field, it is a temporal field. Can you see this? This is nasal field, this is nasal field because it is on nasal field now, and this is temporal field, either ka field, right? Now the fibers of this temporal field fiber is carrying by this, and this nasal field fibers is carrying by this. Just see in the one only. This temporal field, this is the temporal field, and this is nasal fibers. Temporal field, nasal fiber. So the nasal side will carry the fiber of this nasal fiber will carry the visual field of temporal side, and this temporal fibers carry the visual field of nasal fibers. Now forget about this. If you have confusion, forget about this. Just see that this is the temporal fiber, this green one is the temporal fiber, and forget about this, only this half I am talking about. Okay, this is the nasal temporal fiber, this is the nasal fiber, right? Now this temporal fiber is not crossing here, it is going ipsilateral on this side only, but this nasal fiber is crossing. So the nasal fiber crosses to the opposite side. Nasal fiber crosses to the opposite side, right? So if the nasal fiber crosses to the opposite side at the optic chiasma, remember this point. Second point to understand, that if there is a lesion here in the optic nerve, then what is damaged? The temporal fiber of this eye, left eye, damaged, and the nasal fiber of this eye damaged. Basically the whole of the things is damaged. So only this one, matlab before the chiasma, if anything is damaged, because no crossing have been take place, कोई crossing नहीं हुआ है, before the chiasma no crossing have been taken place, that is in optic nerve. If there is a problem, then whole of either this field, temporal field, either nasal field will be zero, like in this condition. So this is the optic nerve lesion, right? And since the lesion in the left side, this is the lesion on the left side, so obviously the lesion, there is a left side optic nerve ka transduction ho gaya. Now coming to this optic chiasma, there are so many things. The optic chiasma ऐसे कटेगा. First vertical dissection समझ लेते हैं. If there is a optic chiasma lesion like this only, what is happening? The nasal fiber of this and the nasal fiber of this, इस आंख का nasal fiber, इस आंख का nasal fiber दोनों कट हो गया, but the temporal fiber and the temporal fiber of both the eye is normal. Only nasal fiber में problem आया, only nasal fiber gets affected, but the temporal fibers जो ipsilateral जा रहा था, that is going, which are going ipsilateral only, they are spared. So the nasal fiber is carrying temporal field. So the nasal fiber is carrying the temporal field. So obviously the temporal field of both the eyes affected. So the temporal field, see, this is the temporal field and this is the temporal field of both the eye is affected. So it is temporal, though temporal, that is bitemporal hemianopia. So if any condition is saying you that the patient is having a bitemporal hemianopia, the lesion is where? Here, at the optic chiasma. And for the simplification of the things, I must tell you, just remember one and only one thing. Beyond optic chiasma, if anything happened, beyond optic chiasma, is anything happen, it will be always homonymous hemianopia, like this. Either this and this will go, or this will go. Beyond optic disc, it is always the homonymous hemianopia. Homonymous hemianopia, or you can just say contralateral homonymous hemianopia. Means if there is a, this is right now. Here it's just, see, this is the right sided lesion. This is the right sided lesion. This is right. So only the right sided, This is the lesion in this area. Suppose this is the left-sided lesion. Sorry, this is the left-sided lesion. Left-sided lesion. Okay. So it's a left-sided homonymous hemianopia. So if it is the left-sided homonymous hemianopia, so obviously the lesion will be in the right side because it is contralateral. Remember this. Beyond optic chiasma, there is always homonymous hemianopia, contralateral homonymous hemianopia. If you see it is a left-sided contralateral homonymous hemianopia, the lesion will be in the right side. The lesion will be in the right side. Or if I can draw like this one, and the lesion here, the lesion in the right side of the that is right-sided contralateral hemianopia, the lesion will be here only. The lesion will be here, right? So this is very important to understand. 3 golden rules. Before the optic chiasma, there is a complete blindness of the same eye. At the optic chiasma, always remember bitemporal hemianopia. And beyond optic chiasma, there is a contralateral homonymous hemianopia. That's it. Now this is the figure of this condition. 3 things that I want to say you. See, the radiation is going like this now. The radiation is going like this. Before it going posteriorly, it goes to the occipital lobe, which is shown here. Before it is going into the occipital lobe. This is the occipital area. Okay. If this is called the Mayer's loop. So sometimes they have asked you the question of Mayer's loop also. So since it is low, since it is below it are inferior fibers, because superior fiber, these are superior, these are inferior fibers. So inferior fiber carry the superior visual field. And since it is only the inferior fibers, so obviously the superior field is going. This is called pi in sky. Pi in sky. They have asked you the question. This is in the occipital lobe. Occipital, sorry, not occipital, temporal lesions. Now, sorry, not occipital, it's a temporal lesion. It's passing into the temporal one, not occipital. And superior fibers in the parietal lesion. The superior fibers here are in the parietal region. So parietal lesions can cause the superior fiber damage. Superior fiber carrying the fiber of field of inferior one. So obviously this is pi in flow. Pi in flow. So do you have to remember this pi in sky and the pi in flow. Now these 2 things that you have to remember. Sometimes they ask you the macula sparing thing, and sometimes they ask you the macular cortex lesion. So anterior, if there is a not complete posterior, if there is a complete posterior involvement, then there is a macular cortex, macula is only involved. Okay? Or you can say, or in the posterior cerebral PCA injury, posterior cerebral artery injury, only this will involve. But in the middle cerebral artery injury, this is occur. So this is not of your importance. I will tell you about the detailed version of this in the separate class. Okay, don't worry. Now this is about the 5th number question. Now coming to the 5th number question. A 30-year-old female represents with a redness, pain in the right eye. Examination reveals IOP of 38, aqueous flare and corneal precipitates. So this is, which of the following drugs must be avoided? So first you have to diagnose the disease. Patient is having the redness, patient is having the pain in the right eye. Obviously IOP is very high. And there's aqueous flare and corneal precipitates. What is your value? IOP high means glaucoma. Aqueous flare is the first sign of the uveitis. So corneal precipitates. So obviously the patient is having an anterior uveitis with secondary glaucoma. So the diagnosis here is anterior uveitis with secondary glaucoma. Obviously the drug of choice will be the steroid, but you know the steroid increases the IOP, and obviously steroids induces the ROP, so you have to try anti-glaucoma drug. They are asking which anti-glaucoma drug should not be given, should be avoided. So those which increases this anterior uveitis, it should be avoided. Beta blockers, very, very, very rarely, and that's why it is not included. Mannitol, not at all. Carbonic anhydrase inhibitors, not at all. So answer is prostaglandin. Prostaglandin is the one which can increase the anterior uveitis. Okay, this is very important. Now coming to this side effects of the aqueous flare, the anti-glaucoma drugs. Can you see this? There is a lengthening of the eyelashes. So this is the defect of the prostaglandin. There is a iris discoloration is taking place. Black, I mean there is, just see, there is the iris discoloration taking place. So this is also a side effect of the prostaglandin. And heterochromia of iris is also the feature of the prostaglandin. So you should not give this prostaglandin in the active infection. Now what is this? This is the conjunctivitis, right? And what is this? And what is this? Can you see the blepharitis type of things? And there is subcongestion here. So these both are the feature of brominidine. Very important. Although this is also caused by the carbonic anhydrase inhibitor. Carbonic anhydrase inhibitor also causes the blepharoconjunctivitis, but the most commonly causing disease is the brominidine alpha analogs. Okay, what are the other? Beta blocker you should not give. Beta blocker you should not give in the bronchospasm patient and the cardiovascular patients, because it increases the mortality here. And not mortality. Brimonidine is also considered to be the neuroprotective, and that's why most of the cases, like in the Parkinsonism also, you have seen that this has been tried. Okay, so brimonidine can be considered. If somebody asks you which one anti-glaucoma drug which is neuroprotective, then you should answer the brimonidine. Coming to this last important question, that is identify the condition. Sometime they have given you, they will give you this type of strabismus question. Then how to proceed this type of question, let me tell you. Suppose this is the photo. First see the primary photo. First see this photo. Then go upward, this direction, in this direction, and then in this direction. So your aim is to see first this, then this, then this, then this, and then this. Okay, now see, the patient is in the primary, this is the primary position. Patient has to see bilkul seedha, straight, but this eye is deviated laterally. May be indicative of lateral rectus hyperactive or spasm, or medial rectus palsy. Now see upper. The patient has tried to see upper, but the patient eye is not moving up. It is still in the left eye, lateral direction. See here, same condition. The patient eye is not going down, but is still into the lateral direction. Now come here. The patient is trying to see left. Obviously, this has tried. Now it is okay, but it is very much deviated, right? See, here the patient has to see in this right direction. This eye, right eye is very good, but left eye does not move. Means this gross, I guess the gross idea that there is a medial rectus palsy, even there is a it cannot move superior rectus palsy or inferior rectus palsy. This is just indicating like that only, right? So till now you can devise that there is some problem in most of the recti, right? So you have to come to the conclusion that there is some palsy that is supplying in most of the area, like third nerve palsy, right? So obviously, if you don't come to the diagnosis, then only you go there. But at your label, they will ask, you will get to the point only by seeing these 5 photos, right? So obviously the answer here is oculomotor nerve palsy. Nothing to discuss more. This is very important point to understand. So please just subscribe and share this, and just repeat this, see all the concepts behind here. I know that there is some bit of confusion in the visual field wala thing. There is a separate video of 5 minutes. Just go through that. I will tell you the point and the trick to solve that question. Okay, thank you for your kind attention, and just click on the bell icon to receive the information about the part 2 of image in ophthalmology, and also INICET December 2021 repeat questions. Thank you very much.